Welcome to our roundtable discussion on PARP inhibitors. My name is Gratzke. I'm a urologist from Germany, and I have a wonderful panel I would like to introduce you to. Starting with Dr. Elena Castro, medical oncologist from Spain, Dr. Andrea Necchi, oncologist from Italy, and Dr. Bertrand Tombal from Belgium. We have a format where we have 3 presentations. 2 will be on prostate cancer and 1 will be on bladder cancer. We'll have 2 prostate cancer presentations first, then a discussion, and followed by the bladder cancer presentation, and again a discussion. So we'll start with Dr. Bertrand Tombal on PARP inhibitors, for which mutations and when. Bertrand, floor is yours.
Yes, so thank you for the invitation. So indeed, PARP inhibitor have become a major player in the care pathway for patients with advanced prostate cancer. We are still at the beginning, but the topic of for which mutation and when is becoming very hype. So these are my conflict of interest. So when we speak about PARP inhibitor in prostate cancer, we still have a limited number of indication because it's EAU. I limit myself to the EMA indication. So we've got olaparib, and I put the commercial name in case you're not yet used to this drug. It is indicated as monotherapy for the treatment of adult patients with BRCA1, BRCA2 mutation in the metastatic CRPC setting. Assuming they have progressed following prior therapy that include a new hormonal agent. And we have no very hot topic in combination with abiraterone and prednisone or prednisolone for the treatment of adult patients with metastatic CRPC in whom chemotherapy is not clinically indicated. We have niraparib, which in prostate cancer is under a specific name. It's called Akiga. It's in a fixed dose combination with abiraterone acetate, so a single pill for the 2 agents, and it is for the treatment of adults with metastatic CRPC patient and BRCA1, BRCA2 mutation in whom chemotherapy is not clinically indicated. We're going to speak about talazoparib and rucaparib. There is no yet a specific indication, at least when it was screened from the EMA website. So what we are speaking is metastatic CRPC patient. These are the patient I call historical metastatic CRPC, meaning somebody which has been on ADT and is progressing and is becoming metastatic castration-resistant prostate cancer. And then we have what I call the intensified metastatic CRPC, the new metastatic CRPC patient, meaning patient who have received ADT and one of the pathway inhibitor very early on, either because they were newly diagnosed with metastatic disease or they were non-metastatic CRPC. So first observation, with time, most of the patient will receive ADT plus AR pathway inhibitor. So these are 2 different groups of patients, and we believe that with time, the blue will become more frequent. So let's start with the blue, because for the blue we have a very high level of evidence. So this comes from the work done by Johan de Bono and others, showing that olaparib has a high response rate in patients with DNA repair mutation. Profound was a very large trial based on 2 cohorts, BRCA1, BRCA2, ATM, and other alteration, meaning that the patient had been pre-screened for DNA repair mutation. You know that study very well. Huge benefit on PFS. I would like to draw your attention on the hazard ratio. We are speaking about 70% risk reduction in progression and a very significant benefit in overall survival for the BRCA1, BRCA2, including also strangely at ATM, but there was a design with a very high benefit in overall survival. Not so clear, not so positive, not positive at all in the patient with other DDA alteration. Toxicity, that's where we learn, I would say, the typical toxicity of this class of agent. You're going to find that across all the PARP inhibitor at different level, but basically you have a triad, which is anemia, nausea, and fatigue. Anemia requiring transfusion. And something I want to draw your attention is basically, to me, the most important indicator, which is the rate of discontinuation due to the adverse event. You are in a clinical trial, and at some point you decide that the toxicity is no longer acceptable and you decide to stop it. It goes from 9 to 16%. So I think that is clear, that is easy. every patient progressing on ADT plus an AR pathway inhibitor should be tested. And if the patient is shown to be BRCA1 or 2 mutated, I believe that as a standard of care, that patient should be offered olaparib 300 milligram BID. This is a standard of care, and we're not going to come back on this. Where it's becoming more to be discussed, and these are the two trials, Propel and Talapro, sorry for the small spell check, because they open the possibility actually to administer a combination of abiraterone or enzalutamide with a PARP inhibitor, olaparib or talazoparib, without any screening. So that what I call the do not even screen agnostic position. So there are two levels of discussion. The first one, the result of the trial. The second one, do we need to screen or not? So very briefly, Propel, abiraterone and olaparib, very large trial, proportion of patients with HRR mutation, which are similar to that I've mentioned before, kind of 10% of BRCA2, 2-3% of BRCA1, a very significant benefit on PFS. And then this is from ASCO GU a few weeks, a benefit in OS, which is, 0.05 we could criticize, but actually this should be considered as positive. So the conclusion is that, and that's important in the intent to treat analysis, the PFS is positive, the OS is positive. So based on this, I put myself in the shoes of the regulator in Europe, and they say, based on this, we approve the drug. Talazoparib, not approved yet, but similar story, patient receiving enzalutamide and talazoparib, very low number of patients progressing from abiraterone, so we're still in a pure historical metastatic CRPC setting. Major benefit on PFS, 0.63, in favor of the combination talazoparib and enzalutamide. Not fully mature yet in terms of overall survival, but we can foresee the future that we're going to get similar result, abiraterone, olaparib, enzalutamide, talazoparib. So technically, based on the intent to treat analysis, we can say that the drug, one is licensed already, the other one will be probably, so we could start treating these patients in a purely agnostic way. I don't want to know what is the DNA status. I don't believe it's such a good idea not to test. First one, for 10 years, we've been trying to have biomarker. Know that we have a good one, we would not use it. Second, side effects are quite substantial, resulting in more heavy monitoring. We know that dose interruption for olaparib or placebo is up to 50%. Discontinuation of olaparib or placebo is 17%. So if you are confronted with a patient which has severe side effect, you would like to know what benefit you do expect. And this is the same, this is Propel, and this is roughly the same in talazoparib. We may discuss of differences, but that's not really the topic of today. And this is the Talapro. You see dose interruption, dose reduction, discontinuation, 1 patient out of 5. And the second argument is that when we look at the benefit, it is clearly very important for BRCA1 too. So you don't want to deny these patients the combo treatment, but it is disputable for other patients. This is the PFS in Propel. You see that the benefit, the hazard ratio for the BRCA group is 0.23, so major benefit. 0.76 for the non-BRCA patient. We have rejected drug based on this. And when we look at the overall survival in the mutated patient, this is striking, undisputable. In the other one, we're going to have to discuss benefit patient by patient. So, in concluding, I see 2 conclusions. I'm going to give a regulatory conclusion. In a patient progressing on ARPI, you should test the patient. If it's BRCA1, BRCA2, you should go for olaparib. I believe that's very high level standard of care. In the patient progressing on ADT alone, there is a scientific rationale to recommend the combo, even in an agnostic population. This is probably what the regulator, EMA, will say. But I would oppose to that we have a great biomarker. We want to know what is the benefit for the patient. So I really believe that we should test the patient, because so we know we can offer olaparib, abiraterone, or niraparib, abiraterone, or talazoparib, enzalutamide to the BRCA1, BRCA2, and then discuss case by case during the treatment and before the treatment with the patient. Thank you for your attention.
Bertrand, thank you very much. Clear message, very nice presentation. I think we'll continue with Dr. Castro, who's going to talk about what's in the pipeline for PARP inhibitors in prostate cancer. Please.
Thank you, and thank you for inviting me. I'm very pleased to be here today. And as Bertrand just mentioned, there's been different clinical trials testing the efficacy of PARP inhibitors in monotherapy for patients with advanced prostate cancer. We have had trials with niraparib, talazoparib, rucaparib, and olaparib, testing efficacy of these drugs in patients who had already progressed to several lines of therapy and consistently demonstrated a clear benefit for patients with BRCA alterations, and not so clear for patients with other HRR alterations, although the issue is that in many of these trials, the number of patients with these less frequent alterations is small, and we may need more data to fully understand that. And based on these studies, the olaparib and rucaparib have currently been approved both by EMA and the FDA. Olaparib in Europe to treat patients with alterations in BRCA1, BRCA2, whilst in the States it is available to treat a wider population with alterations in HRR genes beyond BRCA. And as Bertrand already mentioned, we have now data from PARP inhibitors in combination with hormonal agents that have demonstrated the efficacy for first line of therapy, first line of mCRPC, and in Europe, EMA has already approved olaparib plus abiraterone regardless of biomarker status. So there is a rationale for combining PARP inhibitors with different agents, trying to expand the benefit of these compounds beyond those patients with HRR alterations. So the first one could be the combination of PARP inhibitors of difficulty in the DNA repair, combined with agents that increase the DNA damage or that also prevent DNA repair. We have also the rationale for combining PARP inhibitors with immunotherapeutic agent based on the fact that if you have an increased neoantigen production and T-cell activation, and then you add the PARP inhibitor, the PARP inhibitor and the immunotherapy, that could have a synergistic effect. And perhaps what is more appealing to us at present is the combination of PARP inhibitors with other compounds that target pathways that modulate the homologous recombination function, such as the androgen receptor pathway, the VEGFR pathway, or the PA3 kinase AKT pathway. And there are multiple clinical trials currently going on with different PARPs, with different combinations at different stages of prostate cancer. We have already learned the results of these studies, and I guess in the next years we will learn more and more about potential synergies. So recently, we learned the results of the combinations between PARP inhibitors and immunotherapeutic agents, which has been quite discouraging. And in the K-Link 010, we haven't seen any benefit on rPFS or overall survival by combining pembrolizumab and olaparib. And in Checkmate 9KD, the addition of rucaparib to nivo seems to be only beneficial for patients who have HRR alterations, and it's not clear yet whether the nivo is indeed avoid adding anything to the PARP inhibitor. So not very promising, this combination, I will say. We've also learned the data from combining olaparib with cediranib, and in patients without HRR alterations, there is no benefit. There seems to be a benefit in HRR altered patients. However, again, it's not clear whether the olaparib cediranib is a VEGFR inhibitor is actually adding to the PARP inhibitor, and the association, the combination was associated with a 60% grade 3/4 toxicity versus 18% with the PARP inhibitor alone. So, no very exciting combination at this time. And Bertrand already presented the data of the trials that have combined androgen receptor inhibitors with different PARP inhibitors. I have to say that we have seen different efficacy between these combinations, which could be related to the PARP inhibitor themselves. They have different potency to inhibit the target, but also the hormonal agent is different. So abiraterone is inhibiting this synthesis of steroids, whilst enzalutamide directly inhibits the androgen receptor, and this may affect the synergy. So we have seen a very clear, very positive efficacy in patients with BRCA alterations that is greater than in patients with HRR alterations beyond BRCA, which is still greater than in patients without HRR alterations. And when we analyze the entire population without considering HRR status, the benefit for these patients is in between HRR mutated and non-mutated. And finally, there is a new generation of PARP inhibitors being developed, and these new drugs seem to be more specific inhibiting PARP1 and not PARP2, and this may result in a better toxicity profile. Thank you. Thank you for attending.
Well, thank you very much to you both. So we start the discussion, and I would like to start with Bertrand, because you mentioned the quote-unquote historical cohort of patients only receiving ADT monotherapy. Now we have abundant evidence, whether it's an mHSPC or mCRPC, that monotherapy is not as good as combination therapy. Yet there was a recent survey in the US showing 40% of urologists will actually prescribe ADT monotherapy. Maybe in Europe it's even more. So what's your take on the amount of patients really that are on monotherapy for ADT? And maybe you can enlighten our audience one more time how you would actually deal with those patients.
So I think that we can't say there is no patient like this anymore. I mean, there are many reasons. There are still many countries who don't have any ARPI indicated in metastatic hormone naive. We still have some people who are not prescribing in non-metastatic CRPC. So it's never going to be 100%. However, progressively with time, that pool will increase. And then you have all the patients who started hormone therapy like 4 or 5 years ago and who are going to re-enter the disease. So that pool will exist. So today, the standard of care for these patients, if you believe APCC or the EU guideline, if you have somebody which is progressing on ADT alone and is progressing, you recommend abiraterone or enzalutamide. So you have your own choice. So the question today is, if you like abi, would you give olaparib together, or niraparib? If you like enza, would you give talazoparib? And then the big question that will come will be, should I do that right away, or should I test my patient to refine the question about, which to me is the most important, the balance between the benefit and the toxicity. Because we're going to get 10% of the patient who have a huge benefit. So it's very important. If they develop toxicity, you're going to say, guy, we're going to do maximum. If, on the other hand, you've got somebody who doesn't have any DDR mutation and is developing severe toxicity, you're probably going to stop the drug rapidly. So I personally believe there is a very good rationale to give these drugs in combination. I'm absolutely more dubitative about the interest for the patient to do that in a fully agnostic manner. I understand that for today, for many urologists, it's still very difficult to get DDR checked, but we have to work on that as well. We have to work on the companion testing. Circulating DNA will come. So I believe that if we really want to use this combination, we should check, because my worry is that we may stop treatment too soon in patients who have BRCA mutation and then get a huge benefit, and we can overtreat patients. So I don't see a good reason not to check these patients.
So let me come back to that. Some people propose that because testing might be an obstacle in many countries, it certainly is in my country, the willingness is actually very low, surprisingly low, given the fact that November 2020, the monotherapy was actually approved in my country. Some would propose that you should actually be testing at the beginning of the diagnosis in the prostate cancer biopsy samples. Then you would have the information right away, and when you need it, you know it.
You can do that. We had a lot of discussion of what is the optimal time to check. I mean, that we know that you can acquire mutation over time and that your status may be difficult, but like in Belgium, we did that first test on what you have. If you have a good biopsy sample with a good quality, go with that. Second, you can do germline, but then you may miss a lot of patients. But I agree with that. We need to have a simple way. You have a biopsy, send it for testing, and then build up on that. So to me, that would be much better than not do test anymore. So that would be, I would agree to live with that.
So when it comes to biomarkers, there is a lot of discussion about PSMA being another biomarker you can actually use. And of course, PARPs have a very competitive substance that is on the rise, and we've seen many data now with lutetium PSMA treatment. The question is how to select your patients based on various biomarkers, based on HRMA status, based on PSMA status, because that will be one of the questions in the near future to select your patients on.
At this point in time, it's very easy. We are then speaking on the patient of progressing on ADT, let's say, plus enzalutamide, okay? And then you have multiple options. You can give docetaxel if has not received docetaxel yet. Soon we may have PSMA upfront, pre-docetaxel. If you had docetaxel, you have cabazitaxel, and if you have the PARP. We don't have a lot of comparative data. Yeah. The only one we have is Caba PSMA. I would really advocate that this patient need to be tested, because then it's clear, BRCA1, BRCA2. And when you see the benefit of BRCA1, BRCA2 in that subset, I mean, I would go for that. Then the PSMA, it's already very early on. We know that like the level of SUV is important. If you have a weak expression on PSMA, it's different that you have a high expression on PSMA. That's why also many people would like to promote PSMA lutetium in a PSMA agnostic way. I would say no, PSMA itself is a great biomarker. We should use it as well. And that's all we're going to decide. So yes, today, somebody progressing on AbbVie, let's say, to change the drug, he should get tested and he should have a PSMA. And based on the whole of this, we may decide.
If I may add on that, the BRCA, going back to your previous question, BRCA status seems to be quite stable. And if there is an alteration, it was already present in the primary tumor. So it will be great if we could test patients from the very beginning. But the PSMA, I think, is more dynamic.
Right.
And fortunately, PSMA PET is quite easy compared to genomic testing. And so perhaps it would be a very good approach to sequence the tumor as soon as we can, so we can understand what type of tumor this patient has. And we may have to repeat PSMA PETs several times during the evolution. There may be new lesions that do not express PSMA, and that may change our approach. But yes, I think, and now we only have data for BRCA and HRR, but I guess eventually P10 may also be relevant for treatment with AKT inhibitors. We may learn more about the potential role of P53, RB1 loss. So I think we should not walk away biomarkers.
Very good point. Elena, can I ask you a follow-up question? You mentioned the combination of checkpoint inhibitors and PARP inhibitors. Avenue was presenting the data at ESMO, the Keeling 10 data, was completely negative. You showed that. We had four phase 3 negative trials combining pembro with other substances in the mHSPC and mCRPC setting. Do you see any future for a PARP inhibitor with a checkpoint inhibitor? And if yes, maybe because in these phase 3 trials, I think we have to go back because we know there are responders for checkpoint inhibition. We just don't know who these patients are. To find out what parameters they have, what characteristics they actually have, and then treat them accordingly. What's your opinion?
No, I agree with you, and I can add very little to that. We know who are the patients that respond to the PARP inhibitors. The fact is that we don't know who are the ones that respond to the checkpoint inhibitors. And I think we need to work on that, and perhaps the combination in these patients will work, because otherwise what we have seen from these trials is we need to select patients, and everything points out in the same direction. We need to select, we need biomarkers. And in some situations, we don't know the biomarkers, but in others we do. So let's use those biomarkers and keep working.
Yeah. Well, having said that, the new generation of PARP inhibitors that you mentioned, can you tell our audience a little bit about what we have to await? Is there anything exciting coming along? And if yes, which advantages would you actually foresee? Would there be more on the efficacy side or on the tolerability side?
Mm-hmm. It would be mostly on the safety side, on the tolerability, because with the current PARP inhibitors, what they do is that they block PARP1 and PARP2. And PARP2 is involved in some hematological pathways. So if we do not inhibit PARP2, it seems that the hematologic toxicity will be less, which at present, as Bertrand mentioned, is the main concern with PARP inhibitors. So it will be very nice to see whether the efficacy is the same if you only inhibit one PARP, but with less toxicity. If we are able to achieve that, that would be great, and it will be easier to combine these drugs with other agents, including chemotherapy.
Fantastic.
If I may, it's interesting to realize that the pathway for targeted therapy in personalized medicine in GU cancers is pretty much similar, because if I think about the developments in FGF receptor inhibitors in bladder cancer, the issues are almost the same or quite similar to those with PARP inhibitors in prostate cancer. So the reliability of the test, the reliability of the biomarker, the difference in the biomarker testing and the difference in the assays that are aimed to test the presence or absence of the biomarker, the affordability of the biomarker test, and there is a big issue of affordability and the big issue of geographic disparity, because if the biomarker becomes the major player here, as it is in the case of BRCA, as in PARP inhibition, there is a huge problem of affordability of, as Bertrand has mentioned already, of affordability of the test in the real world. For real-world patients, of course. So there is not just the affordability and the availability of the drug, but the availability of the test that may allow you to get the drug. So this multiplies the issues of drug availability and geographical disparity potentially. And finally, the right timing to test the patients, and how to use and when to use tissue versus liquid biopsy at best. So these are all issues that apply to PARP inhibitors in this case, but may apply to all others, or other personalized medicine in the GU space, and not just in GU.
That was a perfect transition from prostate cancer to bladder cancer, and therefore I suggest we start with your presentations on bladder cancer and PARP inhibitors.
Yeah, thank you very much. Thank you for the invitation. It's a pleasure to be here. So my task is really easy or difficult at the same time, because PARP inhibition in urothelial cancer it's very infancy. We have very limited data. These are my disclosures. So basically, we started in the pre-modern era with initial findings, initial case reports provided in an era when ADC or most of the evidence with immunotherapy were still not available in these patients. But the first cases that reported interesting results in terms of response rate and tumor shrinkage in far pretreated tumors, in far pretreated patients, chemotherapy-treated patients, immunotherapy-treated patients that were tested in an off-label way with the comprehensive genomic profiling test, and they were found to, whose tumor was found to harbor any kind of HRR alteration, in particular in these two case reports, BRCA2 loss and BRCA2 genomic alteration. And these two cases were both outstanding responders to olaparib and to PARP inhibition. So they were the first hints toward the possibility of using this class of agent also in at least in selected patients with bladder cancer. Based on this, a few trials have been run in the urothelial cancer arena. This is the first trial that was run by the first author and PI was Petros Grivas here. The Atlas study was targeting the chemotherapy-treated population, so second and later line setting. Please note the fact that here in the Atlas study, we currently define that the homologous recombination defect positive status as the presence of loss of heterozygosity with a cutoff of 10%. So a different way of defining the genomic instability, not just testing the single gene or gene set, but looking at different potential biomarkers as a surrogate for HRD status. No objective responses have been seen in this study, so the study was closed, and no further developments have been planned in the advanced stage with rucaparib. Other studies that presented reported data and have been published more recently were quite more compelling. The first one is the Atlantis study, which was conducted in the UK, testing rucaparib as a maintenance therapy after response to first-line chemotherapy in patients with locally advanced or metastatic urothelial cancer. In this case, patients were selected for DDR genomic alteration. Interestingly here, when using the same Foundation Medicine approach with the selection of 15 genes that are basically the same that are used in prostate cancer when selected patients for PARP inhibitors. The primary endpoint was progression-free survival, and the study did not meet the primary endpoint, but provided interesting findings of potentially numerically higher PFS rate in HRR positive patients without any major signal in overall survival. So a first hint towards a potential role of patient selection with this class of agent. The other study was a small Italian study looking at the different compound in niraparib, in this case, in unselected patient population in the same clinical setting, maintenance therapy after response to frontline chemotherapy. In this case, again, patients were unselected. They were retrospectively evaluated for genomic alteration with the same panel of genes. The study was negative. The primary endpoint was PFS, and as you can see with the Kaplan-Meier curve here, there is full overlap between the two arms. The third study, and the last one, which presented data regarding PARP inhibitors, is actually a combination study, a combination of durvalumab and dolaparib versus durvalumab and placebo in frontline patients who were cisplatin ineligible with metastatic urothelial cancer. The study was led by John Rosenberg and was led by Memorial Sloan Kettering in the United States. Patients in this case were not selected for HRR genomic alteration, but were retrospectively evaluated for these mutations. And the study was again provided here a signal towards improved PFS, and in particular improved PFS in HRR positive patients, while no signal was seen in unselected patients. So in summary, this is additional data related to a potential prognostic effect of HRR alteration in this disease, but there is conflicting data, heterogeneous data regarding the prognosis of patients harboring or not any HRR genomic alteration in this disease. So in summary, the data on PARP inhibitors in urothelial cancer are converging towards a potential use mainly in combination therapy, in combination with immunotherapy preferably, rather than monotherapy, and preferably in biomarker-selected patients, so in patients harboring any kind of HRR genomic alteration. Again, here with the potential preference of BRCA over the other gene alteration. So, as Elena has already mentioned, there may be a potential overlap in biomarker of efficacy between immunotherapy and PARP inhibitors. Here in bladder cancer, seeing that may be a potential pathway to follow, at least in selected patients. But all the movements around PARP inhibitors in this setting should take into account the fact that we may be struggling against the huge developments that have been made with the ADC developments and the ADC IO combination, in particular in the frontline setting. So everything should be compared to the big data that have been developed with the EV Pembro combination. There are, of course, studies that are running today in second line setting or maintenance setting with combination therapies. So we will see. It's quite hard that these phase 1-2 studies will change the future landscape of the disease, at least at the medium term. But there may be an option, at least, for clinical research in this disease. So, in conclusion, and recapitulating the previous issues and the previous problems and the limitations that we have already discussed, these are the major pillars that should be put on the table when dealing with PARP inhibitors or targeted therapy in general in urothelial cancer. The eligibility will require patient undergoing genomic testing. So the affordability of the test and the right timing for the test for HRD status, and we don't know which kind of assay is the best to use in defining the HRD status. Is the single gene testing, the PCR for BRCA testing is sufficient, or you should use a more comprehensive test looking at the loss of the heterozygosity, tumor mutational burden, and other potential surrogate for PARP inhibitor efficacy. And the last point, of course, has to do with the right sequence, the right therapeutic sequence of the patient. And in this case, there may be a role for additional players beyond immunotherapy, beyond ADC, beyond targeted therapy against FGF receptor inhibitors. So PARP inhibitors may still have a role in very selected patients as a sequential therapy in order to provide the patient the best sequence for the best clinical outcome at the end of the day. Thank you.
Thanks very much, Andrea. Great presentation. This is a very early stage, right? Bladder cancer and PARP inhibitors. Mono treatment, you showed that many negative studies, combination, slight positive trends, if you will. What do you suggest? I mean, I guess my take-home message is we need to find better biomarkers and select our patients in a better way to find the very few patients that might profit from that combination. Yeah. How are we going to do that? What's your approach? What's your suggestion?
Well, I'm a bit biased because I'm a big fan of perioperative therapies. Mm-hmm. But honestly, I think that also when dealing with PARP inhibition, in particular with combination therapy, there is room for investigating earlier disease settings. You know that in muscle-invasive disease, for example, the rate of and the level of TMB is a bit higher as compared to metastatic setting. Other biomarkers that are potentially well suited for PARP inhibition and immunotherapy are pretty more represented in the early disease as compared to metastatic settings. So if I had to invest on the next steps with PARP inhibition, in particular with combination therapy, I would put my coin on perioperative therapies, some kind of neoadjuvant or adjuvant therapies.
So you rather would focus on the right patients and not on the right combination. That would be the second step, because you could speculate upon the question whether or not you should combine PARP inhibitors with other agents than checkpoint inhibitors, for example. Yeah. And maybe make a suggestion what combination could be of potential use, but I guess that's hard to answer, right?
Yeah, we are still at the very beginning of the journey. There is a huge issue of safety, of course. We don't know actually what could be the safety profile of combining PARP inhibitors with the FGF receptor inhibitors, for example. We don't know too much regarding the landscape, for example, of genomic alteration beyond HRR's genomic alteration, or the genomic landscape besides FGF receptor 3 alterations. So maybe accumulating data on the frequency of co-occurring mutation, for example, in this patient may be quite well suited in order to envision a potential for combination of precision medicine, combination of targeted therapy, for example. But I'm very, very worried about the translation of the data, of the evidence from trials to real-world practice in this case, because we are dealing with something that is quite far from the real world. So making the case that we succeed in identifying a signal of positive effect with any of the combination therapy that we may test, the road to routine practice is quite long for a number of reasons that we have already discussed before.
Thank you very much. We're coming to the end, but I would like to ask each one of you a very last question. If you would tell our audience about the major challenges, maybe in a short answer, that we will foresee in the next year or two to come in the field of advanced prostate cancer, to give us an outline of what you think is going to be abundantly important, what would you say? Bertrand?
I would say it's going to be the complexity that comes with multiple drugs.
Right.
So I have only one command: read the paper, learn how to give all the drug, and get organized with colleagues to take the best decision for each patient.
So education is the key.
Education remains the key.
Right. Dr. Castro.
I totally agree with Bertrand, but just to say something different, even if we don't have access to tumor testing, or if it's not reimbursed and it's difficult in prostate cancer, we know that we have some germline alterations that are somehow quite frequent, that is easy to test, that this is in place for other tumor types, and that can really change the prospects of some families, because if we detect these alterations, the families will benefit from early detection programs and prevention programs. So if we cannot test the tumor, at least test the germline.
Great statement. Thank you very much. Andrea, you get the last word.
Yeah, the last word is easily related to the multidisciplinarity.
Right.
Because there is a huge role for a revitalized issue related to the multidisciplinarity that may take into account the role for molecular pathologists, the role for a geneticist, so a newer role for new players that may come into the arena of prostate cancer and then potentially other geocancer treatment for everyday practice, not something that has to do with clinical research, but has to do with clinical decision making every day.
Fantastic conclusion. I would like to thank you all for discussing that important topic with us. Thank you to the audience for listening to us, and I hope that you will continue our education in that prospect. Advanced prostate cancer is a very complex topic where we have to learn a lot, but there's important advances to be made. So thank you very much for listening and watching us. Have a good day.